What bariatric surgery really is today. Welcome to Bariatric Surgery 360. Today we begin a new series about modern bariatric surgery in the United States. Clear, direct, evidence-based, no myths. If you are considering weight loss surgery, or simply trying to understand how bariatric surgery works today, stay with us until the end. Because what most people think about bariatric surgery is outdated. 20 years ago, it was often described as a last resort, an extreme operation, high risk, large incisions, long hospital stays. But modern bariatric surgery has changed dramatically. Today, it is a highly standardized, minimally invasive metabolic treatment supported by decades of clinical research. And the numbers tell an important story. In 2022 alone, approximately 280,000 bariatric surgery procedures were performed in the United States. The majority of those were sleeve gastrectomy procedures, making it the most common type of weight loss surgery in America today. Yet despite these numbers, this represents less than 1% of Americans who actually qualify for bariatric surgery based on medical criteria. That means millions of eligible patients never pursue evaluation. Why? Because many still believe outdated myths. Let's be clear. Bariatric surgery is not cosmetic surgery. It is medical treatment for severe obesity and metabolic disease. More than 40% of American adults currently live with obesity. Severe obesity significantly increases the risk of type 2 diabetes, hypertension, obstructive sleep apnea, fatty liver disease, heart disease, stroke. Clinical guidelines in the United States recommend weight loss surgery for individuals with a body mass index of 40 or higher, or a BMI of 35 or higher with obesity-related conditions such as diabetes or hypertension. For certain patients with poorly controlled type 2 diabetes, even lower BMI ranges may qualify under updated recommendations. But here is what truly defines modern bariatric surgery. It does not simply make the stomach smaller. It changes hormonal regulation. It alters hunger signaling. It improves insulin sensitivity. It reduces chronic inflammation. It affects how the body processes energy. This is why it is often called metabolic surgery. Procedures such as sleeve gastrectomy and gastric bypass influence hormones like ghrelin and GLP-1. That is why many patients with type 2 diabetes see dramatic improvement within days after surgery, even before significant weight loss occurs. This is not starvation. This is physiological recalibration. Modern bariatric surgery is also safer than many people realize. Large U.S. studies show that the 30-day mortality rate after bariatric procedures is approximately 0.3%. That is comparable to, and in some cases lower than, other common abdominal surgeries. In accredited bariatric centers, procedures are performed laparoscopically. Small incisions, shorter hospital stays, reduced infection risk, faster mobilization. But the biggest transformation over the last 2 decades is not just surgical technique, it is structure. Today, weight loss surgery is part of a comprehensive medical pathway. Before surgery, patients undergo metabolic testing, cardiac evaluation when necessary, nutritional assessment, psychological screening, education sessions. After surgery, life after bariatric surgery includes structured bariatric diet phases, mandatory vitamin supplementation, regular laboratory monitoring, long-term follow-up appointments. This is not a quick fix, it is a medical partnership. Studies show that patients typically achieve 20 to 35% total body weight loss within 6 to 24 months after procedures like sleeve gastrectomy or gastric bypass. More importantly, many patients maintain substantial weight reduction for years when they follow structured post-operative care. And beyond weight, outcomes improve. Diabetes remission rates are significant. Blood pressure often stabilizes. Sleep apnea improves. Cardiovascular risk decreases. Bariatric surgery today is not an act of desperation. It is an evidence-based treatment for a chronic disease. And when performed in accredited centers under standardized protocols, it is one of the most effective long-term interventions available for severe obesity. But understanding what bariatric surgery truly is, and what it is not, is the first step. In the next section, we will explore the most common procedures in detail: sleeve gastrectomy and gastric bypass. Because choosing the right procedure requires clarity, and clarity reduces fear.
Sleeve gastrectomy versus gastric bypass. Understanding the difference. When people hear the term bariatric surgery, they often assume it is a single procedure. It is not. In the United States, the two most common types of weight loss surgery are sleeve gastrectomy and Roux-en-Y gastric bypass. Together, these two procedures represent the vast majority of the approximately 280,000 bariatric surgeries performed annually in the U.S. Sleeve gastrectomy is currently the most frequently performed bariatric surgery in America. It accounts for more than half of all procedures nationwide. Let's understand why. During a sleeve gastrectomy, approximately 75 to 80% of the stomach is removed. The remaining stomach is shaped into a narrow tube, or sleeve. This reduces stomach volume significantly. But volume reduction is only part of the story. The portion of the stomach that produces ghrelin, the primary hunger hormone, is largely removed. As a result, appetite decreases. Hunger signals become less intense. Patients feel full with smaller portions. This is why sleeve gastrectomy is not just restrictive. It is hormonal. Patients typically experience substantial weight loss during the first year. Clinical data shows that total body weight loss after sleeve gastrectomy often ranges between 20 and 30% within 12 to 24 months. Now let's examine gastric bypass. Roux-en-Y gastric bypass is both restrictive and malabsorptive. In this procedure, a small stomach pouch is created. The small intestine is rerouted to connect directly to that pouch. Food bypasses part of the stomach and upper intestine. This produces three major effects: reduced food intake, altered nutrient absorption, powerful hormonal shifts. Hormones such as GLP-1 increase significantly after gastric bypass. This improves insulin sensitivity and glucose regulation. That is why many patients with type 2 diabetes see rapid improvement, sometimes within days after surgery. Research shows that remission rates for type 2 diabetes following gastric bypass can be substantial, especially when surgery is performed earlier in the disease course. In terms of weight reduction, gastric bypass patients often achieve 25 to 35% total body weight loss within the first 1 to 2 years. Both sleeve gastrectomy and gastric bypass are effective, but they are not interchangeable. Sleeve gastrectomy is often preferred for patients seeking a technically simpler procedure, individuals without severe reflux disease, patients concerned about long-term malabsorption. Gastric bypass may be recommended for patients with severe gastroesophageal reflux, individuals with poorly controlled type 2 diabetes, patients requiring stronger metabolic intervention. Complication rates for both procedures are low in accredited centers. The overall 30-day mortality rate for bariatric surgery in the United States is approximately 0.3%. That rate is comparable to other commonly performed abdominal procedures. However, no surgery is risk-free. Potential complications can include bleeding, infection, blood clots, anastomotic leaks, bowel obstruction, dumping syndrome, nutritional deficiencies. But structured preoperative screening and postoperative monitoring significantly reduce these risks. The key point is this: bariatric surgery today is highly protocol-driven. Nothing is improvised. Every step follows standardized guidelines developed by organizations such as the American Society for Metabolic and Bariatric Surgery. Surgeons operate within accredited programs. Hospitals follow strict safety protocols. Patients undergo detailed evaluation before proceeding. This is modern weight loss surgery, not experimental, not extreme, but carefully structured metabolic therapy. Choosing between sleeve gastrectomy and gastric bypass requires individualized assessment. Medical history, metabolic profile, reflux symptoms, diabetes status, eating behaviors. There is no universal best procedure. There is only the right procedure for the right patient. In the next section, we will explore something many people overlook: life after bariatric surgery, because the operation itself is only one day. The long-term outcome depends on what happens afterward, and understanding the bariatric diet and follow-up structure is essential for success. Life after bariatric surgery. What truly determines success? For many people, the focus is entirely on the operation, but the most important phase is life after bariatric surgery. The surgery itself may last less than 1 hour in experienced centers. Recovery in the hospital may last 1 to 2 days. But long-term success is built over months and years. Life after bariatric surgery begins immediately. In the first days after procedures such as sleeve gastrectomy or gastric bypass, patients follow a carefully structured bariatric diet. This diet is not optional. It is a medical protocol designed to protect healing tissue and ensure metabolic adaptation. The stages typically include clear liquids in the first phase, protein-rich liquids in the second phase, pureed foods, soft foods, then gradual introduction of structured solid meals. This progression allows staple lines to heal, inflammation to decrease, the stomach pouch to adapt safely. Protein becomes the priority. Most patients are advised to consume between 60 and 100 grams of protein daily, depending on body size and medical guidance. Hydration becomes intentional. Because fluid intake cannot occur at the same time as meals, patients must sip water consistently throughout the day. Vitamin supplementation becomes lifelong. Daily multivitamin, vitamin B12, iron when indicated, calcium with vitamin D. Without supplementation, nutritional deficiencies can develop. Iron deficiency anemia, vitamin B12-related neuropathy, bone density loss, chronic fatigue. Structured follow-up dramatically reduces these risks. Laboratory testing is typically performed several times during the first year and then annually. Weight loss during the first year after bariatric surgery follows a general pattern. The first 3 to 6 months often bring rapid reduction. Between 6 and 12 months, weight loss slows. Most patients achieve between 20 and 35% total body weight loss within 6 to 24 months after sleeve gastrectomy or gastric bypass. For example, a patient weighing 300 pounds may lose 60 to over 100 pounds depending on procedure type and adherence. But life after bariatric surgery is not only about numbers on a scale, it is about metabolic improvement. Studies show that many patients experience significant improvement or remission of type 2 diabetes, reduction or elimination of blood pressure medication, improved lipid profiles, reduced sleep apnea severity, lower systemic inflammation. Research also suggests that long-term mortality risk decreases after bariatric surgery compared to matched individuals with untreated severe obesity. However, surgery does not eliminate responsibility. High-calorie liquid intake, such as sweetened coffee beverages, alcohol, or milkshakes, can bypass restriction entirely. Frequent grazing throughout the day can override satiety signaling. Ignoring the bariatric diet can slow progress or lead to regain. Life after bariatric surgery requires behavioral adaptation. Food may have previously served as comfort, stress relief, celebration, coping mechanism. After surgery, physical capacity limits those patterns. Some patients experience emotional adjustment. Support groups, dietitian follow-up, and psychological counseling when necessary improve long-term success. Exercise also plays a critical role. Physical activity preserves lean muscle mass during weight loss. It improves insulin sensitivity. It enhances mood and energy levels. The goal is not extreme training, it is consistency. Walking, strength training, structured movement. Long-term outcome depends on alignment between physiology and behavior. The surgery creates metabolic leverage. The bariatric diet protects healing. Follow-up monitoring ensures safety. But daily choices determine durability. Life after bariatric surgery is not about perfection. It is about structure. Structure in eating, structure in supplementation, structure in follow-up, structure in movement. And when that structure is maintained, weight loss is not only significant, it is sustainable. In the next section, we will examine why modern bariatric surgery is considered one of the safest major abdominal procedures performed today in the United States. Because safety concerns remain one of the biggest barriers preventing eligible patients from seeking evaluation. And clarity reduces fear, surgery versus GLP-1 medications. The real decision. Now we arrive at the most important question. If bariatric surgery is safer today, if sleeve gastrectomy and gastric bypass are effective, why are so many people choosing medications instead? Drugs like semaglutide and tirzepatide, often referred to as GLP-1 medications, have changed the weight loss conversation in the United States. They reduce appetite, they slow gastric emptying, they improve insulin sensitivity. Clinical trials show that GLP-1 medications can lead to average weight loss of approximately 10 to 20% of total body weight, depending on dosage and duration. That is significant, but there are important differences. First, sustainability. GLP-1 medications require continuous use. When treatment stops, studies show that a substantial portion of the weight lost may return. This is not failure, it is biology. The medication influences appetite signaling while active. When discontinued, the original hormonal drivers often reappear. Bariatric surgery works differently. Procedures such as sleeve gastrectomy and gastric bypass create structural and hormonal changes that do not depend on weekly injections. Weight loss after bariatric surgery typically ranges from 20 to 35% of total body weight within 1 to 2 years. And long-term studies suggest that many patients maintain substantial weight reduction for a decade or longer. Second, metabolic impact. GLP-1 medications improve blood sugar control, but gastric bypass in particular has shown high remission rates for type 2 diabetes, especially when performed early. Some patients experience normalization of blood glucose within days after surgery. Not months, days. That is metabolic reprogramming. Third, long-term data. GLP-1 medications are promising, but long-term outcome data beyond several years is still developing. Bariatric surgery, on the other hand, has more than 2 decades of longitudinal data. Large U.S. studies show reduced cardiovascular risk, improved life expectancy, lower all-cause mortality compared to untreated severe obesity. And remember this, more than 40% of American adults live with obesity. Millions qualify for weight loss surgery, yet less than 1% undergo evaluation, often because of fear. Fear of risk, fear of complications, fear of permanence. But modern bariatric surgery has a 30-day mortality rate of approximately 0.3%, comparable to other common abdominal procedures. Performed laparoscopically, small incisions, short hospital stays, it is not the surgery of 20 years ago. It is structured, accredited, protocol-driven. Now here is the emotional truth. Choosing between GLP-1 medication and bariatric surgery is not about which one is better. It is about readiness. Some patients prefer medication. Some patients respond well to it. For others, severe obesity has progressed for years. Diabetes worsens. Blood pressure climbs. Joint pain increases. Sleep apnea strains the heart. For these individuals, bariatric surgery may provide stronger and more durable metabolic change. But surgery requires commitment. Life after bariatric surgery means following the bariatric diet, taking lifelong supplementation, attending follow-up visits, making structured food choices. It is not passive, it is partnership. Medication requires consistency too. Weekly injections, cost considerations, insurance approval, potential side effects. Neither path is effortless. Both require engagement. The real question is not surgery or medication. The real question is, what level of intervention does your health require right now? If obesity is mild to moderate, medication may be appropriate. If obesity is severe, progressive, and accompanied by metabolic disease, bariatric surgery may offer stronger long-term protection. The goal is not aesthetic change. It is risk reduction. Lower cardiovascular events, reduced diabetes complications, improved mobility, longer life expectancy. And here is what matters most. Bariatric surgery is not surrender. It is not weakness. It is a medical decision grounded in evidence. And when performed in accredited centers, supported by multidisciplinary teams, and followed by structured life after bariatric surgery care, it can be transformative, not only physically, but psychologically. Because reclaiming control over your health changes how you see yourself. If you want clarity, not fear, about bariatric surgery, sleeve gastrectomy, gastric bypass, the bariatric diet, and the realities of life after bariatric surgery. Stay with us. Subscribe to Bariatric Surgery 360 and tell us in the comments, what decision are you currently facing? Surgery, medication, or still uncertain? Because informed decisions reduce fear, and clarity changes outcomes.